expert panel assembled at the front, and Wendy has been taking your questions. We'll start with these. If there's something that has occurred to you during these talks that you didn't write down, we got microphones right there. So we'll start with this. Wendy's going to quarterback the Q&A. But again, if there's something on your mind, feel free to go to the microphone.
You have more? Wow. Oh boy. Okay.
You can't submit your own question.
Wow.
Should I go through some of the last ones?
Do you mind doing that? Okay, there we go. Okay, so the first question is, I always call it the elephant in the room. I am concerned about the side effects of biologic medications. What is the risk of cancer as a result of taking biologics?
So it's a great question. We've used the biologics for about 15 years. They came in about 1999, 2000. As you might recognize, they're blocking tumor necrosis factor, right? So that sounds, if you think about it, why are we blocking something that kills tumors, right? So it's always had this uneasy dimension of concern. The good news is, Dr. Laura, we have a chair for you here. See her quads as she's coming up. There have been two major concerns. One is cancer. So when the biologics first came in, it seemed like patients with rheumatoid arthritis and spondylitis were having lymphoma at a higher rate than expected. They were compared to the healthy population, but when they compared against rheumatoid and AS patients had equally severe disease, there was no signal for the biologic. It's called confounding by indication. We are actually comparing apples and oranges. So the consensus seems to be in the large databases that there's no significant increased risk of cancer with the long-term treatments. In fact, some cancers, prostate and colorectal cancer, seem to be actually down. Cardiovascular risk actually seems to be down. And the thinking there is that if you control inflammation in your body, this is not just in AS and rheumatoid arthritis, this is true in inflammatory bowel disease and psoriasis, that you're reestablishing a much more healthy body of homeostasis or balance. With respect to infections, as you're aware, we always screen for tuberculosis and certain viral hepatitis infections. In our data, in our population here, we've surveyed to see whether the biologics in and of themselves increase a risk of infections, and the answer is no. So baseline screening seems to be a very good check. As you know, if you have an intercurrent infection while you're on a biologic and you're taking an antibiotic, we put that on hold. And then, so Richard, do you have a question?
Just to follow up, are the risks the same for IL-17 inhibitors?
Yeah, so it's a good question. Richard's question is the IL-17 concern. So there's been a concern, for example, about fungal infections. Like if you look at the immunologists tell us that IL-17 is important for defense against fungal infections. So things like candidiasis in the mouth. So far, the signals have been fine, but we only have about 2 to 3 years of observation with the IL-17, specifically secukinumab. Whereas we got 15 years, well, almost 20 years with TNF. So far, the safety profile looks good with the 17 inhibitors. Next question.
Okay. Another biologic question for Dr. Haroon and Dr. Inman. If a biologic is stopped for 3 to 4 years or more because of symptoms, back pain, are relieved, what happens in terms of response if the biologic needs to be restarted after 3 or 4 years?
Yeah, it's a great question, and it's often asked in the clinic. We don't have a clear answer, but there is a theoretical possibility that when you have something external to the body introduced and it's taken away, it gives an opportunity for the body to fight back, right? Because we are introducing an immunosuppressant, our immunity is suppressed when the drug is being administered. You take the drug away, our immunity gets activated, and it tries to fight anything foreign. And what is foreign in the body is the drug that we're giving. So there is a theoretical possibility that our body will produce antibodies against the drug. So when you come in at a later time point with the same drug, either it could act at a big less effective, or the antibodies could cross-react and you can get reactions, and allergic reactions. So there's a theoretical possibility. We have seen that happen, but not always.
Okay, thank you. This is a question probably for Dr. Flannery and Dr. Bartlett and Laura. Both Susan and Laura and Dr. Flannery recommended exercise being so important. But what should people do who are in too much pain to get out of bed, never mind exercise? So do one of you want to start it and hand it over?
So too much pain to get started. It's a very challenging question, absolutely. I usually try to frame things or reframe things. People do get up and do their function. So taking a history that elicits some of that function that's actually there demonstrates that although it feels like they cannot get out of bed, they actually do get out of bed and start. So pain is your enemy that destroys you, so really trying to make sure that they understand the concept that just continue to move is going to help them. It's going to, so, we used to say that, back pain many years ago, we said, people just stop and go rest. We found out that that was probably the worst thing we could have ever have told people to do. So that example shows how the deconditioning, do people have a sense of how quickly you become deconditioned if you stay in bed? Let's say you stay in bed for a week. How much muscle mass are you likely to lose? Anybody, just throw out a number. 0.5%? 50%. If you stay in bed for 1 week, 30 to 50%. So when you start to frame things around not moving, people then start to go, oh my God, now I get it. That's why rehab has been so effective at helping people get up, because our team, our interprofessional team, gets spinal cord injury patients up and mobilized, or brain injury patients up and mobilized, or stroke patients, all of those different health populations. Chronic pain is the same thing. Getting them up and moving is really one of the important aspects. So reframing to understand the consequences of not moving becomes a very good motivational aspect around that. And understanding then that there might be some methods, that's where the medications can be used proactively rather than reactively. So taking the medication to take away some of that pain to enable you to function. So that, again, a concept of reframing is one way that I use.
I would say that from the psychologist perspective, we follow that up with trying to understand with what the person is saying to themselves, because they're probably saying something like, I'm just going to give myself another easy day, and then I'll feel better tomorrow, and I'll feel more like doing it tomorrow. It's kind of Scarlett O'Hara. When the reality is, and this is assuming that the physicians have cleared you, the physiotherapist has said you should be moving, that what you need to be doing is fake it until you make it. So looking at what you're saying to yourself, and are you really helping yourself by saying these things, or are you staying stuck?
And I think approaching activity in general, no matter what it is, it has to be gradual, but you have to stick to the plan. So there are days that you're going to feel great, where you're going to be able to jump out of bed and off you go, and chances are you're going to feel pretty awful the next day because you're not used to that level of activity. Then there's going to be days that you really have to push yourself. So that idea of that gradual introduction to activity is on the days you feel good, still stick to the plan. Only do that 30 minutes or whatever it is that you said you were going to do. The days that you feel bad, you got to push yourself to do those 30 minutes. And you just stick to the plan and keep going each day, one at a time.
Okay, so just building on that, actually, there's another question is, are there any videos or apps that you would recommend for exercise?
So actually, I've got 3 of the same question here.
Yay!
So there's all kinds of great online resources. So the CSA has great online resources with links to other organizations, with links to the Arthritis Society, which has a great new website with tons of resources. In terms of apps, there are a few apps out there specific to ankylosing spondylitis. They vary in terms of content and comprehensiveness. So some are very basic, others get into more detail in terms of exercises available. And again, in terms of technology, and I mentioned this in the talk, the idea of activity trackers can really be helpful in terms of monitoring your activity, setting goals, giving you reminders. Like even just for example, if you have a sedentary job and just simply standing up and sitting back down so you're not sitting for hours on end. Just set the timer so it goes off, or on your smartphone, so that, boom, it goes off every 30 minutes to remind you to go up, take a little walk, get a drink of water, and sit down. So it's little things, like it doesn't have to be advanced technology, it can be very simple things. But online, there are a lot of good resources out there.
Sorry, that might be something that we can actually work together and kind of assess and put some more resources on our website. So you can jump in.
Sorry. One of the things that was actually done by one of our previous fellows was he assessed the online literature that was available for ankylosing spondylitis. And he actually rated it in terms of literacy, accessibility. That was Ahmed's poster at ACR. So there have been some studies that have actually looked at content and quality of online work. So yeah, we can definitely work.
Just a follow-up question here on in terms of resources. So this is for Dr. Susan Bartlett. Could you list potential sources for counseling therapy, especially for students in low-income?
So the nice thing about students, if you're a university student, is that most universities, in fact all universities that I can think of in Canada, have counseling centers and they offer counseling for their students at no cost. The other thing that's an incredible resource, especially if you're in a major metropolitan area like this, is you've got University of Toronto, York University. They have clinical psychology programs, social work programs, counseling psychology programs, a lot of students, and these students need training, and they have clinics that are available to the community. The clinics run on a sliding scale, so they will work with you to make sure that finances are never a barrier. And you get outstanding counseling, quite frankly, because the students are very carefully selected and they're closely monitored. But it's a great opportunity to be able to go in and sit down and talk with somebody and get treatment at a much reduced cost to going and seeing your average psychologist or social worker or counselor.
Perfect, thank you. Here's another one actually for you, Susan. What do you recommend people do whose loved one is clearly depressed and won't do anything?
That's really tough, and I know that you will get calls from time to time. We've talked about this before. You know, the thing is, it comes back to the communication that I talked about a little bit earlier, and it's frustrating. So you have to find a time, you have to find a space, but it's, I think, very important and very motivating to patients when their family members are honest. These are the changes I see in you. These are the things that we used to do that we don't do anymore. Here are the things that I don't hear you saying before. You used to love this, and this, and now the hockey games aren't of interest to you. So when family members are able to reflect that back to patients, that can often be the key that helps patients say, you're right. They may not know what to do about it, and so then again you can be a real help by saying, let's see if we can find somebody that you might be able to talk to about this. And often it makes a world of difference if you'll just go with the person to the appointment, to the first appointment, and sit down. It's just that little bit of energy and nudge and support that they need to follow through. Once you get them into someone like my office, we know what to do. But the huge barrier is getting them in and just making the contact.
Okay. Do you have other questions within your pile? Or?
Just a question here. Can AS affect the shoulder and the jaw? Certainly. We mentioned Achilles tendonitis. This disease has a propensity to inflame sites where tendons insert into bone. Right? So like around the heel, for example, and around the shoulder. All the tendons around the shoulder can become quite inflamed. We can see it on an MRI sometimes. Jaw involvement does occur. It's not that common in our clinic, but it certainly can occur. So the shoulder can sometimes, a local steroid injection can help, less so with the temporomandibular joint, but if they're both active, they kind of tell the rheumatologist we're not really on top of the game. We might have to change the treatment game plan. There was also a question about dyskinetic movement. That would be very unusual in our clinic. So if someone's experienced a dyskinetic, like movement disorder in the setting of spondylitis, we'd usually have them see a neurologist, right? So once in a while, there are neurological side effects with the biologics. They're very unusual, but we have a few patients in our clinic that have experienced some neurological side effects. So in a setting like that, we, as rheumatologists, we would ask for advice from the neurology team.
Okay, in looking at AS triggers in the research, what role does stress or traumatic events play? So I'm not sure who wants to try to address that.
It's an interesting, one of the paradoxes of AS is that exercise and loading joints is a good thing, but there's some research that it might be too much of a good thing that might backfire. So there's some studies in experimental models that if you load an inflamed joint, it seems to be a little worse. There's also some work to suggest that patients with AS that have physically demanding jobs, so like car mechanics, electricians that are hyperextending or repeated manual lifting, if you compare those versus a less mechanically loading job, career path, it might have an adverse event. So I think what we're looking for is the right amount of exercise. As Laura said, it's got to be smart exercise. Whether trauma can actually trigger this event, this does come up in our clinic because somebody might have been relatively stable and they have slip and fall off a ladder at work, or they get rear-ended at a red light. And all of a sudden, a trauma, the injury to the spine seems to accelerate the trajectory of the disease. We don't really understand what that is. We think that in patients with AS, your immune system is sort of hyperactive, and it might be an infection, it might be an accident like trauma, but you have a hyper-reactive response to that. So there is some evidence, and I'm saying there may be people in this room who can look back at an event, an injury or an accident that seem to accelerate things. But we don't think it's really causative, but it might be accelerating.
So I'll just add to that. I have a very different take on stress and trauma when I hear those words. Stress, the kind of stress, psychological stress, is like throwing gasoline on everything. So the best predictor of when somebody's going to flare is when they're going through stress. So you need to become a good stress manager. That's really important. In terms of trauma, psychological trauma, there's growing evidence that one of the environmental switches, somebody was talking about this earlier, is trauma. Because a substantial number of people have experienced a major trauma in their life in the year prior to diagnosis. So we know that the mind is really important in terms of not only the onset of the disease, but also how things are going to go over time. Really important to get good at managing stress.
Okay. Dr. Flannery, how do you recommend handling a physician who will not prescribe pain medication? Sorry,
Again,
that's a tough one.
Yeah, it is. I think, and we're running into a lot of this with opioid, recommendations to curb and stop opioids. It's just prevalent, and we actually lecture on how to do that tapering aspect or have the conversation. And the new Canadian guidelines that came out in 2017, which were the second set of guidelines, had a lot of additional information which we had gleaned because the first set of guidelines in Canada in 2010 by my former fellow and now rock star leader in chronic pain, Andrea Furlan, she established that there were some parameters that we could follow, and subsequent to that, research got better. And we could start to see, looking specifically at the causative effects of high dose of opioids, that there's a lot of problems. Opioid-induced hyperalgesia, suppression of the adrenal axis so that people can have suppressed gonadal effects, and people can have osteoporosis as a result of this because we're suppressing all their testosterone, men and women. So there's a whole bunch of things like sleep apnea syndrome. So the effects are great. The evidence, the guideline about the weaning part is actually only a weak recommendation. So it's very difficult. We're kind of in a clinical equipoise right now around how best to manage this group. We're getting more information. I think asking for a referral to a pain clinic that might be able to assess whether these are helpful or not, if it's from a family physician. If it's in a pain clinic, it might be worthwhile to have a second opinion to sort of make sure, because I think you do need an honest opinion as to whether or not the opioids are beneficial for this individual, and I would usually look at function, and that's what we try to encourage people to look at. If it's helping you and you're improving, not just your number going down, but improving you overall, that can be helpful. It's not dissimilar to what we do for the emotional aspect, is taking a reflective view. So those are a couple of suggestions that I might look at.
Okay.
Having an honest conversation with your family doctor is another thing to sort of say, what, you know, are you worried about addiction? So there is a self-management tool that Dr. Furlan and one of our nurses worked on, a My Opioid Manager, which is available. It's an app that can look at some of the education around how to use opioids. So it gives you an idea to sort of say, are you using them in the most effective means, which might help with the education with the physician. But it is a very difficult and sensitive area, and people do feel as if they're under kind of siege around this push to just get everybody off opioids. And they can be really helpful in certain individuals, no two ways about it.
Thank you. I think Dr. Helen was...
There is a follow-up question for Dr. Flannery. So just to put it in context, I presented the recommendations for management of ankylosing spondylitis. So we generally start with anti-inflammatories and then go on to biologics. And if the patients are still symptomatic, then generally we take the help of a pain clinic or a pain person. So what are the tools in your kit that can help manage pain in these patients?
So I think we talked a little bit about it, the 3 M's. So the medications are one. Looking at mood and how mood affects, and if there is some presence of some dysfunctional mood aspects, having it addressed. It doesn't always mean a medication, it just means maybe counseling, making them aware, and so on. And then the mood medications, and I'm blanking on my own third, the mindfulness that people have, because cognitive methods are very effective at assisting individuals. The meds, interventions can be quite effective. So we've, in the right individuals, spinal cord stimulators can be fantastic. And what are the right indications? When it's leg dominant pain as opposed to back dominant pain. So back surgery for back pain, a bad idea. Back surgery for leg pain, a very good idea. Back surgery or back stimulators for back pain, a bad idea. Back stimulators for leg pain, a good idea. So it prevents some of the neurologic consequences. So understanding that concept around some of these interventions are helpful. Sometimes the interventions like steroid injections, and Jill was asking me about that, do I do it? The SI joint's a very difficult area to get into, so now with ultrasound guidance, we can get in much more effectively and make sure that it's not judged as a negative result because we actually didn't get into the SI joint. And ultrasound is a very easy tool to do as opposed to fluoroscopy, which involves a little bit of radiation. So there are different methods to manage the interventions, and we've got that whole gamut that we look at in our pain assessment.
Okay. Laura, what type of cardio do you suggest for somebody with extremely limited breathing due to no rib cage expansion?
So, it's a good question. Again, when it comes to cardiovascular exercise, it really has to do with your effort. So what moderate intensity for me, for example, might be different than Dr. Haroon. So I think it depends on the individual. And as long as you're getting your heart rate up to that target heart rate, then I think that you're going to be achieving cardiovascular fitness. And so, as I mentioned, one way of doing that is through the talk test. So if you're sweating, but you're able to engage in a conversation, then you're likely working within a moderate intensity, which is around 70% of your maximal heart rate. Other things that you could do is wear like a heart rate monitor. Most equipment at gyms have sensors that will indicate your heart rate. So it really has to do with more your effort that is involved with the specific activity that you're engaging in, and that will then translate into cardiovascular fitness.
Okay.
Oh, I do have another question if you want
Sure,
to keep
yeah,
going.
go ahead.
I gotta put these on. So the question is, this is related to the ball. How long should I sit on an exercise ball? So, as I mentioned, just simply sitting on a ball is going to improve core strength. So often, and this is good for people who are just starting to engage in exercise, I will suggest take the ball, get the ball, again, you want to sit on it with your hips and knees at a 90-degree angle, and watch TV for half an hour. And at commercials, although commercials are kind of a thing of the past now with Netflix, but you'll get the idea. So at commercial, do some leg lifts. So what you're doing is you're decreasing the base of support of the ball and you're wobbling a little bit more, and it's putting more, it requires more core strength to stabilize the ball while you lift up your legs. So I mean, that's a very simple exercise that you could do, and that's like half an hour. Other people will actually just take the ball to work. They have sedentary jobs where they sit at a desk and sit on a ball for half an hour and then throw the ball in the corner, sit on a chair, and then alternate back and forth. Some people will sit on a ball for the whole day. But it really is an effective form of engaging the core. It works on your posture, and it's a pretty passive form of exercise, I suppose, if you're just starting to get into exercise. But it's very effective in terms of core strengthening.
You want to go?
Oh, sure. What are the biggest changes in ankylosing spondylitis in 3 different fields? One, diagnosis, treatment, and prognosis. So I can take diagnosis, you can take treatment and prognosis. So in terms of diagnosis, MRI was the biggest change that happened for ankylosing spondylitis. This was introduced in around 2007 or so. And since then, we have been able to pick up a lot of patients with inflammation in the spine and yet having a normal X-ray. So that is how the new classification and the totally new kind of diagnosis of non-radiographic axial SPA was introduced. Now, what we are realizing more recently is that the specificity of this MRI tool is not that great as we thought initially. So in 2007, we were probably overdiagnosing a few patients. Now we know that MRI, if you do MRI on 100 people walking on the street, 20 to 25 of those 100 people could have changes that look like ankylosing spondylitis. So we have to take changes in the MRI that we see in the MRI in context of the symptoms and the other investigations that we have. So just to be sure that we are not overdiagnosing and unnecessarily treating these patients with biologics. That's one of the major changes that have happened in diagnosis. For treatment?
So I'll take that question just and add a dimension with a related question. What AS factors result in changing from NSAIDs to biologics for an AS patient? And secondly, is starting earlier, now given the data that Dr. Hearn showed, starting earlier better? So first on the landscape, about 40% of the patients in our clinic are just on NSAIDs. They get NSAIDs and physiotherapy and exercise, and they're doing fine. So not everybody that has a diagnosis of AS is going to a biologic. So what is the usual dominant factor that moves the clinician, the rheumatologist, from the NSAIDs to the biologics? It's symptomatic control. So the cardinal features of AS being pain, stiffness, and fatigue. When those become unacceptable to the patient, and that's communicated, that we usually establish that contract relationship that we clearly want better symptomatic control. So usually that's the central domain. Now we do use adjunctive measures. We use inflammatory markers like sedimentation rate, CRP. We'll occasionally use a repeat MRI if we're not sure how much inflammation is present, but usually it's anchored in pain control. And the 35 or 40% of patients that are doing very well on NSAIDs, thank you very much, doing their exercises, we're happy with that. Now, the subtext in that question was, but you guys showed that the biologics delay disease progression. So even in that group that seem to be symptomatically, are we missing an opportunity? Very astute question. So the current feeling is that if you looked at that grid that Dr. Hearn showed, remember when the serial studies are followed, probably 75 or 80% of patients in those windows of observation do not progress. So we tend to really stratify looking at prognosis with simple markers. Is a patient a smoker? Yes, no. Is the sedimentation rate or the CRP up? Yes, no. Is there baseline damage? Are there already some bone spurs in the spine? If the answer to those 3 simple questions is no, the patient's in a very low probability of progression. And so we wouldn't think there'd be enough of a case to be made for starting a biologic for a patient whose symptoms are well controlled with NSAIDs. Now, it changes over time. One of the reasons we see our patients every 6 months is that things do change. The disease kind of waxes and wanes, and that's one reason why we do randomized control studies, because there may be a spontaneous remission of a flare that we might attribute to a biologic. So it's, I think, a lot of the long-term relationship we feel fortunate to participate in this observational cohort is that we can modify. We always say, this is the assessment at this point in time. That might change 6 months from now, so let's stay in touch.
Okay, Dr. Haroon, what information do you have on stem cell therapy, and does it look like a promising form of therapy?
Yeah. So far, there is no data on stem cells in ankylosing spondylitis. Having said that, there are a number of studies in rheumatology in general. So essentially, the whole idea is that our immune system develops from the bone marrow. And maybe there is something wrong in the bone marrow cells that are giving rise to the immune system, which is going on to attack the body, the joints. So if you try to remove the bone marrow and replace it with the normal bone marrow, and hopefully the whole entire system can be changed. That's the whole idea behind it. And one area where this has worked in rheumatology is systemic sclerosis. And that's the condition where the skin progressively gets tighter, the lung gets tighter, and it becomes difficult to breathe. And it's entirely driven by a group of cells that cause this fibrosis. So maybe, in some of the trials, by changing the bone marrow with stem cells, this, to an extent, it has been reversed. There has been no such successful trial in ankylosing spondylitis. I'm not aware of any such attempts anywhere in the world as well.
Okay. I think we have time for just one more question, or maybe two, but is there any current research into the microbiome?
Microbiome.
Okay. Microbiome and AS. And then the second question to that is rehabilitation of the microbiome. Third question, how can we volunteer or participate in research studies?
The third one's easy. We're welcoming people anytime for a trial. The short answer, actually, we're not, right at this point in time, we're not enrolling in a NEC trial. But there are new biologics coming on the market, particularly the oral biologics. Sounds a lot more attractive than getting intravenous or subcutaneous. So there's a new class of drugs called the JAK inhibitors that are already on the market for rheumatoid arthritis. They're being assessed for AS. So that's one piece. With respect to the microbiome, so as I mentioned, there's a strong relationship between inflammatory bowel disease and ankylosing spondylitis. We have had patients that start off with a food poisoning episode that seems to be the trigger for the disease. Correspondingly, there have been a number of studies that actually look at the gut. The gut microbiome is looking at the bacterial population that populates our GI tract, which, interestingly, there are more cells there than are in our mammalian cells. We're sort of walking petri dishes, right? So it's a very complicated cellular environment with billions and billions of organisms. But our GI friends are trying to sort out what the relationship of the immune system is with this microbial population, what they call dysbiosis. So there are several studies going on that have addressed this question in AS, that maybe there's something wrong with the microbial population in the gut. Okay, there's supportive evidence. So what are we going to do about it? So in terms of repopulating the gut microbiome, on one extreme we have a disease called that's induced by Clostridium difficile. It's a pathogen it's very common in patients in the hospitals around Canada, where an organism takes over. What's called a fecal transplant, actually where you repopulate the gut with your own fecal bacteria, turns out to be quite an effective mechanism. Now those studies in inflammatory bowel disease, like Crohn's disease, have not been very effective. Could there be something a little more benign than a fecal transplant? It's kind of a weird concept if you get your head around that. For example, treating with antibiotics, or probiotics, or prebiotics. There's one study of probiotics from one of our colleagues in New Zealand that was negative. Anecdotally, we'll sometimes see patients that are taking ciprofloxacin for their Crohn's disease and their arthritis feels better. At the present time, there's no solid evidence that antibiotics really change the activity or the course of ankylosing spondylitis. Nevertheless, we're very interested we think there's a lot of important biological lessons. One of our graduate students found in the synovial fluid of patients with ankylosing spondylitis cells that actually started in the gut. So sometimes the T cells got educated in the gastrointestinal tract, and they ended up in an inflamed joint. Very interesting for an immunologist, right? So we think we're beginning to understand the microbiome better, but there's a long way to go.
Okay. And I think we have time for one more question. This is a common one that I get asked a lot, so I'm anxious to hear your answer. Do you ever combine two biologics in refractory disease?
So I'll start. Previously, it has been tried in multiple diseases, especially rheumatoid arthritis, where especially in the era where there were not many choices. Currently, there are many choices for rheumatoid arthritis. So people try to block two different molecules, so both immune stimulatory molecules, and the result was that because you're blocking two pathways that are important for our immune system, there was a significant increase in infections. So that was given up at that time. Now, especially in the field of ankylosing spondylitis, there is a promising combination available that we have tried and many people around the world have tried. There is a drug called Entyvio, which is specific for the gut. So it helps patients with inflammatory bowel disease. And the immunosuppression is quite gut-specific. It doesn't have a lot of systemic effects. Because it is gut-specific, it doesn't control the arthritis and the spinal arthritis and the peripheral arthritis. So we have started, in individuals where the gut doesn't respond to, for example, TNF inhibitor, we've started combining TNF for the joints and Entyvio for the gut. That's one of those rare situations where you can actually do the combination. There are thoughts around combining the oral drug, the kinase inhibitors, with an injectable drug, but I don't think there's a lot of data around it.
Yeah, I think that there are a couple of compounds that are called DVDs, dual variable domain monoclonals, so they actually block TNF and IL-17. The trials in rheumatoid arthritis don't really look like they add much. They don't add much over, say, the TNF alone. But I think as we understand the biology of the disease better, we're going to get more targeted. And just on that point, we've gone through an interesting evolution in the biologics. So everybody got under the TNF-alpha umbrella. It was good for Crohn's disease, for psoriasis, for rheumatoid arthritis, for ankylosing spondylitis. It just looked like whatever you got, we can fix it, right? Not entirely true, but the next generation of biologics are quite different. So IL-17, which works very well for psoriatic arthritis and ankylosing spondylitis, doesn't work for Crohn's disease. Doesn't work very well for rheumatoid arthritis. That's interesting. If you block IL-23 instead of IL-17, it's dramatic for psoriasis. It doesn't work for ankylosing spondylitis, but it looks pretty good for Crohn's. So we're entering a very interesting, I think the next generation of biologics have got the clinicians and the basic scientists really scratching their heads. Of course, we're all committed to making sure the right drug gets to the right patient at the right time. That question has got some very interesting nuances now, I think. But for sure, the next generation, it's going to be a challenge to customize treatment exactly for the patient. And that'll be good. That's called personalized medicine.
Okay, so I think given the time, we're going on to 8:40. We'll close it down. And there's a few questions that have been answered, and maybe you can come up and ask one of the speakers. I'll just quickly say on behalf of CSA, thank you very much to all the speakers for your presentations and your time to put everything together and traveling from Montreal. You guys spoke, we listened, we brought in specialists in pain and mental health. We're continuing to do more of that, really populating our website with more information, as Dr. Bartlett has pointed out. Mental health is huge. I hear it every single day from people either emailing me or Facebook or whatever. So we're taking it really seriously because we really feel it is a huge factor in your overall improving your outcomes. So there's lots of good things happening at the CSA. Keep following us on the website, on Facebook, and we hope that what we're bringing to you can improve your outcomes and your quality of life. And again, thank you to you guys, and I will leave it to Dr. Inman to just say a few words.
Well, it's been great. I'd really like to thank John and Susan for it. Added a new dimension, and I think one that our patients wanted. Thank you very much. And I thank you all for coming and for your support. I think this is really a partnership between the healthcare professionals across the whole spectrum and the patients. And I think together we're going to win this.
Thank you.